Hi, I'm Dr. Jessica, and I've spent more than a decade of my career sitting across from people in their 50s, 60s, and 70s, listening to them tell me, "But I feel fine," while the cuff on my desk quietly read 160 over 95. So today I want to walk you through, in plain language, exactly what high blood pressure does to a heart that has already crossed the 50-year mark, and what you can realistically do about it. I'm going to assume you know almost nothing about cardiology, and I'm going to explain every term the moment it shows up, because the only way a number on a blood pressure reading makes sense is if you understand the engine behind it. And the engine is the heart we've been carrying around, quietly, for half a century or more. Let's start with that engine. Every single beat of your heart is one complete cycle, and that cycle really only has two phases that you need to remember. The first phase is called systole. That's when the lower chambers of your heart, the ventricles, squeeze down hard and push blood out into your arteries. The second phase is called diastole. That's when those same ventricles relax and refill with the blood that's been returning from the rest of your body. Squeeze, relax, squeeze, relax, about 60 to 100 times a minute, every day, for as long as you live. The phrase cardiac cycle just means one full squeeze and one full relax put together. And that cycle is what produces the two numbers your doctor measures every time they wrap a cuff around your arm. Multiply that single beat by roughly 100,000 beats a day and by 36 million beats in a year, and you'll start to feel why small, repeated changes in pressure matter so much more than the single reading we get on any given visit. Blood pressure itself is nothing more mysterious than a measurement of how hard that squirted blood is pushing against the walls of your arteries. The first or top number in a reading is the pressure at the exact moment the ventricles squeeze. It is called the systolic pressure, and it is the higher number of the two. The second or bottom number is the pressure inside the arteries while the heart is in its relaxed refilling phase. It is called the diastolic pressure, and it is the lower number. So when someone says their blood pressure is 120 over 80, they mean the systolic pressure was 120 millimeters of mercury during the squeeze, and the diastolic pressure was 80 during the rest. Both numbers matter, but they tell you slightly different stories, and as we cross into our 50s, one of those stories starts to change in a very specific way that a lot of patients never hear explained. So what counts as normal in the first place? According to the current American College of Cardiology and American Heart Association guidelines, a normal blood pressure for an adult is a systolic of less than 120 and a diastolic of less than 80. The next step up is called elevated blood pressure, which is a systolic between 120 and 129, with a diastolic still under 80. Stage 1 hypertension begins at a systolic of 130 to 139, or a diastolic of 80 to 89. Stage 2 hypertension is anything at or above 140 systolic, or 90 diastolic. If you're over 50 and your cuff regularly reads 130 over 80, you're no longer in the almost fine zone. You're officially in stage 1, and that number, multiplied by every single beat your heart takes for the next 30 or 40 years, is the first thing I want you to take seriously. Now here's the part that most people don't realize until they've reached this age, and it's arguably the most important part of this whole script. Before about the age of 50, both the top number and the bottom number tend to rise together as people develop high blood pressure. After 50, the pattern changes. The top number keeps climbing, but the bottom number often levels off or even drifts down. This pattern has a clinical name. It's called isolated systolic hypertension, and it is the single most common form of high blood pressure in adults over the age of 50, especially over 60. The reason it happens comes down to what is happening to your arteries, and it's worth slowing down here. Think of the largest artery leaving your heart, the aorta, as a balloon when you were 20 years old. It was stretchy. The wall of that artery was made mostly of two proteins, elastin, which behaves a lot like a rubber band, and collagen, which behaves more like a stiff rope. When you were young, elastin dominated, and the artery expanded to absorb the force of each squeeze and then gently squeeze that blood forward while the heart relaxed. By the time you're 50 or 60, that balance has shifted. Calcium has been quietly deposited in the wall. Collagen has steadily replaced a large share of the elastin. Some of the smooth muscle cells inside the wall have changed their behavior. The arteries have grown stiffer, not because of any single dramatic event, but because of decades of normal aging, plus whatever extra wear comes from cholesterol, smoking, high blood sugar, and chronic stress. A stiff artery doesn't absorb the squeeze, it just transfers the force straight through. That's why the systolic number shoots up in your 50s and 60s while the diastolic number stalls. The artery simply can't cushion the wave anymore. And a heart that pushes against a stiff artery, beat after beat, year after year, is a heart that is slowly being asked to do more and more work for the same amount of blood delivered. So who is most likely to walk this path? The list of risk factors is long and somewhat familiar. Age is at the top, for the reason I just described. Ethnicity matters too. Black adults, for instance, tend to develop high blood pressure earlier in life and to have higher average readings than white adults in the same age group. A family history of hypertension or of an early heart attack or stroke in a parent or sibling loads the dice in a way you can't fully control. Weight matters because every extra kilogram of body tissue means extra miles of tiny blood vessels for your heart to push blood through, and that extra tissue is metabolically active, which is another way of saying it's helping to raise the pressure itself. Smoking damages the lining of the arteries directly and speeds up the stiffening process. Heavy alcohol intake, especially more than 2 drinks a day for men or more than 1 drink a day for women, raises pressure both directly and through weight gain. A sedentary lifestyle, meaning long stretches of sitting with little movement, allows the small arteries to stiffen faster and blunts the beneficial changes in blood vessel flexibility that regular movement produces. Chronic stress keeps the nervous system in a slightly revved up state, which keeps the squeeze phase longer than it should be. And certain medical conditions ride alongside high blood pressure and make it worse, including high cholesterol, type 2 diabetes, obstructive sleep apnea, and chronic kidney disease. You can't change your age, your genes, or your 50 years of accumulated arterial wear. But you can absolutely influence most of the other items on that list, and your heart will respond. Let's walk through the actual mechanism of damage now, in the same order your heart experiences it. The moment your arteries become stiffer and your pressure starts to climb, your heart has to push harder with every squeeze. Do that enough times and the muscle wall of the left ventricle, the main pumping chamber, starts to thicken, the same way any muscle thickens when you keep loading it. Cardiologists call this left ventricular hypertrophy, and we can see it directly on an ultrasound of your heart. A thicker wall sounds like it should be a good thing, like a stronger bicep after months in the gym. It's not. A thicker heart wall is a stiffer heart wall. It can't relax as easily during the diastolic refilling phase, so less blood comes in with each beat. The ventricle fills under higher pressure, which then backs up into the lungs. That backing up is exactly what produces the shortness of breath that so many adults over 50 start noticing, first when they climb 2 flights of stairs, then later when they walk across a parking lot, then later when they bend down to tie their shoes, and eventually when they're just sitting in a chair. The same stiff, thickened ventricle also stops filling the coronary arteries that supply the heart muscle itself as efficiently, which is one of the reasons that chest discomfort with exertion becomes more common as the years pass. At the same time, the chronically elevated pressure is damaging the lining of the arteries themselves. Tiny cracks appear in the smooth inner surface that is supposed to keep blood flowing without resistance. Cholesterol particles, along with other debris floating in the blood, settle into those cracks and begin to lodge. Over years, fatty plaques slowly build up in the arteries that feed the heart, which is what we call coronary artery disease, sometimes just called heart disease. A plaque can grow quietly for decades, or it can rupture suddenly. When a plaque ruptures, a blood clot forms on top of it within seconds. If that clot blocks a coronary artery completely, the muscle downstream stops getting oxygen, and that is a heart attack. If smaller clots or bits of plaque break free and travel up into the brain, they can lodge in a small artery there and cause an ischemic stroke. High blood pressure also directly raises the risk of a hemorrhagic stroke because it weakens the walls of tiny arteries inside the brain over time and can cause one of them to rupture. On top of all of that, high blood pressure is the single most important modifiable cause of atrial fibrillation after the age of 50. because the chronically high pressure inside the left atrium stretches that chamber over time. And stretched atrial tissue is exactly the kind of tissue that starts firing chaotic electrical signals. Once you have atrial fibrillation, your stroke risk roughly doubles, and you may be started on a blood thinner for the rest of your life. And finally, the very same high pressure that damaged the arteries and the heart is also damaging the small filtering vessels in your kidneys, which is why uncontrolled hypertension so often goes hand in hand with declining kidney function in adults over 60. And why a routine blood test called a basic metabolic panel, which most of us get anyway, is actually one of the best early warning systems we have. I want to pause here for a moment because this is the part of the script where, if I've done my job right, you should feel something uncomfortable in your chest. The reason I go through the mechanism step by step is not to scare you. It is because high blood pressure has earned the nickname the silent killer, precisely because most of these changes are happening without any pain, any obvious warning, anything that would make a person pick up the phone and call their doctor. After 50, in particular, the symptoms that do eventually show up can be surprisingly easy to brush off. A little extra fatigue in the afternoon, a small amount of ankle swelling at the end of the day that vanishes overnight, a feeling that your heart is occasionally skipping a beat or racing for no reason, a dull headache in the morning that fades by lunch, dizziness when you stand up too quickly, especially after a hot shower, trouble sleeping flat with a need for an extra pillow to feel comfortable breathing. None of these feel like an emergency, and yet any of them in a person over 50 can be the very earliest signature of the chain of damage I just walked you through. The single most useful sentence I can say in this entire script is this: if you are over 50, your blood pressure is the cheapest, fastest, most informative test your doctor can run, and it should be checked at least once a year, even if you feel completely well, and more often than that if any of the symptoms I just mentioned show up. Now let me give you a few numbers, because numbers are what changed how my own practice handles blood pressure over the past decade. The largest and most important trial on this topic is called the Systolic Blood Pressure Intervention Trial, or SPRINT, and it was published in 2015. Researchers enrolled more than 9,000 adults with an average age around 68, all of whom had high blood pressure but not diabetes, and randomly assigned half of them to a standard target of less than 140 systolic, and the other half to an intensive target of less than 120 systolic. The intensive group had roughly a 25% lower rate of major cardiovascular events combined, a 27% lower rate of heart failure specifically, and about a 25% lower rate of death from any cause. The trial was actually stopped early because the benefit in the intensive group was so clear it would have been unethical to keep people on the weaker target. The Chinese STEP trial, which focused specifically on adults aged 60 to 80, found a similar 26% reduction in combined cardiovascular events when targeting a systolic between roughly 110 and 130. The current European Society of Cardiology guidelines, updated in 2024, recommend a target for most adults under 65 of roughly 120 to 129 systolic over 70 to 79 diastolic, a target of less than 140 over 80 for adults between 65 and 79, and an individualized target for those over 80. So the bottom line is that we now have very strong evidence in people over 50 specifically that pushing the systolic number down toward 120 saves lives, hearts, kidneys, and brains. The catch is that pushing it that low safely almost always requires changing how you live, and in most people it also requires medication, often more than one. So let's talk about what you can actually do, starting with the lifestyle changes that are not optional and that have the largest effect on the smallest budget. First, weight. Losing even 5 to 10% of your body weight, which for many people is just 10 to 20 pounds, has been shown to drop systolic pressure by an average of 5 to 20 points. That is the same size of drop you often get from a blood pressure pill, achieved by changing nothing except what you put on your plate. Second, movement. The American Heart Association recommends at least 150 minutes per week of moderate aerobic activity, which sounds like a lot until you realize that works out to roughly 22 minutes a day, and that brisk walking absolutely qualifies as moderate. Walking after dinner, walking between meetings, walking while you take phone calls. Those minutes add up. Strength training twice a week, even light resistance bands, helps the muscles pull sugar out of the blood and reduces the stiffening of the small arteries. Third, sodium. The current AHA recommendation is to keep sodium intake under 2,300 milligrams a day and to move toward an ideal of 1,500 milligrams a day for most adults. Realistically, most of the sodium you eat is not coming from your salt shaker. It is coming from bread, canned soup, deli meat, pizza, restaurant sauces, cheese, and processed snacks. Reading a nutrition label for 5 seconds and choosing the lower sodium version of the same food every single time adds up fast in a way most people don't expect. Fourth, diet pattern. The DASH eating plan, which stands for Dietary Approaches to Stop Hypertension, has been tested in randomized trials and shown to lower systolic pressure by 8 to 14 points on its own. DASH emphasizes vegetables, fruits, whole grains, lean proteins like fish and poultry, beans, nuts, and low-fat dairy, and limits saturated fat and added sugar. It is not a fad. It is one of the most evidence-backed eating patterns in medicine. Fifth, alcohol. The safe limit for blood pressure purposes is no more than 2 drinks a day for men, no more than 1 drink a day for women, and less is better. Sixth, smoking. Every single cigarette temporarily raises blood pressure and damages the arterial lining for hours afterward. There is no safe level. Quitting smoking is the single biggest bang for your buck change you can make for your arteries, your heart, and your brain, and the benefits begin within weeks. Seventh, sleep. Untreated obstructive sleep apnea, which is extremely common in adults over 50, especially those who snore loudly or feel unrefreshed after a full night in bed, can keep nighttime blood pressure elevated, blunt the effect of blood pressure medications, and quietly damage the heart in its own right. If your partner has been complaining about your snoring for years, that is a medical appointment, not a joke. Eighth, stress. Chronic stress keeps cortisol and adrenaline high, both of which raise pressure. Practical tools like a daily 10-minute breathing practice, a regular walk in nature, time with people you trust, and limiting late-night news and social media are not soft suggestions. They are part of the prescription for a heart that has been working hard for more than half a century. When lifestyle changes alone don't get you to your target, which is common and not a personal failure, medication becomes the next step. The 5 main classes of blood pressure medications that doctors reach for first have changed very little over the past few decades, because they work and because we know how to use them safely. Diuretics, often called water pills, help your kidneys flush out extra salt and water, which lowers the total volume of blood circulating through your system and reduces pressure on the artery walls. Beta blockers slow your heart rate and block some of the effects of stress hormones, which reduces the force of each squeeze. Calcium channel blockers relax the smooth muscle inside the artery walls, allowing the vessels to open wider and let blood flow through more easily. ACE inhibitors, which stands for angiotensin-converting enzyme inhibitors, block the production of a hormone called angiotensin II that would otherwise narrow your arteries and tell your body to hold on to salt and water. ARBs, or angiotensin receptor blockers, do the same thing one step downstream by blocking the receptor that angiotensin II would normally latch onto. Most adults over 50 with diagnosed hypertension end up on 2 of these medications at low doses rather than 1 at a high dose, because the combination is generally better tolerated and more effective, and because lower doses of 2 different drugs tend to produce fewer side effects than a higher dose of a single drug. A practical and honest note. Side effects do happen, and if a medication makes you dizzy, gives you a dry cough, or interferes with your life in any way, your doctor needs to know. There are always alternatives, and the goal is to find the combination that controls your pressure without making you feel worse than you did before treatment. If I could leave you with only one picture of what well-controlled blood pressure actually looks like after 50, it would be this. It looks like a person who goes for a brisk walk most days, eats mostly whole foods without obsessing, takes 1 or 2 small pills every morning without complaint, checks their pressure at home once or twice a week with a validated cuff, sees their doctor 2 or 3 times a year, sleeps well because they finally got their sleep apnea treated, and who continues to live a full and active life because the cumulative damage that would otherwise have shown up in their 60s and 70s simply never got the chance to build. That's not a fantasy. That is what the evidence in trials like SPRINT and STEP and decades of follow-up data consistently show. The heart you have at 50 is a heart that can keep serving you well into your 80s, but only if the pressure inside it is treated like the serious, silent, daily force that it actually is, and only if you decide, starting this week, that it matters enough to do something about. If you're watching this and you recognize yourself in any of the symptoms or the patterns I described, please make one specific, concrete appointment this week. Talk to your own doctor. Bring a list of your home readings if you have them, a list of every medication and supplement you currently take, and a written list of the questions you actually want answered. And if your doctor recommends lifestyle changes, medication, or further testing, take that recommendation seriously the same way you would take a recommendation about a car you depend on every day to get your family where they need to go. Your heart is doing exactly that for you, right now, and it deserves the same kind of careful attention. I'm Dr. Jessica, and I'll see you in the next one.